Welcome to Chapter 45, Part 1, Cerebral Dysfunction and Nursing Care of the Unconscious Child. Let's talk about increased intracranial pressure. The brain is well protected but vulnerable to pressure that may accumulate within the cranium. As pressure increases, signs and symptoms become more pronounced and level of consciousness deteriorates. So early signs and symptoms can be subtle, could be irritability, poor feeding, high-pitched cry, difficult to soothe. Fontanelles could be tense, bulging. They could have separated cranial sutures. Eyes like the setting sun sign. Scalp veins could be distended. They can have a headache. They can have forceful vomiting, seizures, drowsiness, lethargy, diminished physical activity, or inability to follow simple commands. Late signs would be bradycardia, decreased motor response to command, decreased sensory response to painful stimuli, alterations in pupil size and reactivity, extension or flexion posturing, decreased consciousness, coma, and you want to look on page 1418 of your textbook, box 45-1. Okay, looking at coma assessment, you want to use the pediatric Glasgow coma scale. It's a three-part assessment. It's based upon eye-opening, verbal response, and motor response. Score of 15 is an unaltered level of consciousness. Score of 8 or below is a coma. Score of 3 is extremely decreased level of consciousness. Worst possible score on the scale. You want to look at box 45-2 and figure 45-2 on page 1419 of your textbook. Level of consciousness and pediatric coma scale are pictured on the right. So looking at the neuro exam, aspects of the neurological exam in a child are the same as for an adult. Be sure to document the results of the neuro exam carefully so that others following you will be able to accurately compare the results to determine any change in status. Aspects of the neuro exam include vital sign assessment, skin assessment, eye assessment, assessment of motor functioning, assessment for posturing, and assessment of reflexes. You want to look at pages 1420 to 1421. Look at figure 45-3 on page 1420. It's also pictured here. It shows the variations in pupil size with altered states of consciousness. When you talk about posturing, we had decorticate or flexion posturing indicates severe dysfunction of the cerebral cortex or lesions to the corticospinal tracts above the brain stem. Decelerate or extension posturing is a sign of brain dysfunction at the level of the midbrain or lesion or damage to the brain stem. Posturing may be observed when the child is quiet, but may be elicited by applying painful stimuli, a noxious stimuli, or by turning or touching the patient. Be sure that you document what action elicited the posturing. Let's discuss some diagnostic procedures. Laboratory tests that may help to delineate the cause of unconsciousness include a CMP, blood ammonia levels, PT, PTT, CBC, blood cultures if febrile, urine toxicology, and lead level if indicated. We may need an EEG, which may provide important information as to what type and the severity of the brain dysfunction. A lumbar puncture is performed when infection or toxic encephalopathy is suspected. For imaging, we have radiography. It's to rule out skull fractures, dislocations. It's to evaluate degenerative changes and the suture lines. We have the CT scan and an MRI imaging that are also used for diagnosis because they can scan soft tissues as well as solid matter. You want to look at table 45-1 on pages 1422 to 1423 for neurological diagnostic procedures. Okay, so let's talk about nursing care. Outcome and recovery of the unconscious child may depend on the level of nursing care and observational skills. Emergency management, you want to look at airway, reduction of ICP, and treatment of shock. Assessment Parameters should be level of consciousness, pupillary reaction, vital signs, and frequency of the assessment depends on the condition, and it ranges from every 15 minutes to every 2 hours. Patient positioning. You want to avoid neck vein compression, provide alternating pressure mattress, elevate the head of the bed 30 degrees, avoid activities that may increase ICP, eliminate or minimize environmental noise, and they may have suctioning issues. For nutrition and hydration, it's usually intravenous administration of fluids and parenteral nutrition. You want to avoid overhydrating. Later, you may have to decide whether to have gastric feedings via the nasogastric or gastostomy tube, and then you want to continue to monitor for aspiration. Let's talk about pain. It requires astute nursing observation. Some signs of pain are increased agitation and rigidity. ICP is increased by pain, and then alterations in the vital signs, usually increase in heart rate, respiratory rate, and blood pressure, and decrease in oxygen saturation. So let's talk about pain management. Acetaminophen with codeine may be administered for pain. You want to look at Chapter 30 for pain management. We also have opioids. The use of opioids routinely is controversial because opioids such as morphine masks the signs of decreased level of consciousness and will also depress respirations. Regardless if used, Narcan should be available for use and bowel administration should be monitored. Because the stress response to pain can increase ICP, Narcan is a combination of an analgesic, sedative, and paralytic that is often administered continuously via IV administration to block the stress response to pain. Adequate dosage and regular administration is critical to pain control to prevent eliciting the stress response to pain. Comfort measures include proper positioning, limiting visitors to decrease the stress, and avoid the jarring movements. You want to provide a quiet, dimly lit environment to decrease stimulation as well. Respiratory management. Airway management is primary concern. An oral airway can be used for children with a temporary loss of consciousness. Nasotracheal tube may be indicated for children who remain unconscious for an extended period of time, and endotracheal tube for children with a Glasgow coma scale of less than 8. Cerebral hypoxia lasting greater than 4 minutes may cause irreversible brain damage. Carbon dioxide retention causes vasodilation, increased cerebral blood flow, and increased intracranial pressure. Gag and cough reflexes may be minimal. Risk of aspiration of secretions is increased, so child should be positioned to aid in the prevention of aspiration. Okay, so let's discuss monitoring intracranial pressure. So the indications for monitoring would include the Glasgow Coma Scale score of less than 8, traumatic brain injury with an abnormal CT scan, deteriorating neurologic condition, subjective judgment regarding clinical appearance and response. There are 4 major types of ICP monitors. We have the intraventricular catheter. This is a direct ventricular pressure measurement with an intraventricular catheter. It's the gold standard for ICP monitoring. It requires a hole to be drilled in the skull, and the catheter is placed within a ventricle in the brain. Then we have the subarachnoid bolt, also known as the Richmond screw. Placement occurs through a hole in the skull. A bolt is placed in a subarachnoid space. Then there is the epidural sensor. The subarachnoid and epidural monitoring can be used when an intraventricular catheter is not an option. An epidural sensor involves a sensor being placed between the dura and the skull and is less invasive but also less accurate. We have the anterior fontanelle pressure monitor. Both the intraventricular catheter and the subarachnoid bolt can be used to promote drainage of cerebrospinal fluid to decrease the intracranial pressure. For sustained ICP, elevations greater than 20 to 25, mannitol may be administered IV for rapid reduction of ICP It can lower the ICP in 1 to 5 minutes. Hypertonic saline solutions may be used to lower intracranial pressure, also known as ICP, and are beneficial for hypovolemic and hypotensive patients as well. So think about nursing care. Position the child to avoid neck vein compression. Prop the child on one side or the other. Use an alternating pressure mattress to reduce prolonged pressure to vulnerable areas and decrease the risk of pressure sores. Frequently assess neural status. Gentle range of motion may be performed. Do not perform range of motion vigorously. Combine care to reduce the frequency of disturbance and non-therapeutic touch, which can increase intracranial pressure. Ensure that the child's environment remains darkened and quiet to reduce stimuli. Suctioning is contraindicated unless concurrent respiratory problems exist. Nutrition and hydration. Initially, hydration and nutrition are provided parenterally, and then long-term nutrition and hydration should be provided via nasogastric or gasostomy tube, and avoid overfeeding to prevent aspiration. Okay, so let's talk about altered pituitary secretion. Syndrome of inappropriate antidiuretic hormone and diabetes insipidus may accompany central nervous system diseases. Altered pituitary secretion may result from hypothalamic dysfunction. Fluid replacement, electrolyte balance, medications specific to the disorder should be provided. Diabetes insipidus should be addressed. Here's a brief overview of the diabetes insipidus. Look at the picture for details. You have to remember that a head injury or a pituitary tumor or craniotomy can actually lead to diabetes insipidus. Okay, so let's discuss management. Medication regimen is determined by the cause of unconsciousness. Antibiotics for infectious process, corticosteroids for inflammation and edema, sedatives or anti-epileptics, sedation or amnesic anxiolytics, barbiturates, that's kind of controversial, and then paralytic agents. We had thermal regulation because antipyretics are ineffective with a traumatic brain injury, and external cooling methods may be necessary to manage hyperthermia. Elimination. A Foley catheter may be placed to monitor the urinary output. Diapers or briefs may also be weighed. For long-term comatose states, indwelling catheters may be removed, and elimination may be achieved by intermittent catheterization. And then stool softeners may be administered to promote the bowel elimination. Hygienic care. They need routine bathing. You want to perform mouth care at least twice per day and assess eye routinely for need of artificial tears or lubricants. Positioning and exercise. Elevate the head of the bed at least 30 degrees. Place the child in a side lying position and perform range of motion exercises gently. And then use of supports and splints to prevent the foot drop and the severe contractures. Stimulation. When the child's condition permits, holding or rocking helps to soothe the child. Auditory and tactile stimulation may help to arouse the child. You want to involve parents and family members in stimulation. And then family support. Nursing support depends on the nature of the child's condition, the parent's personality, and the parent-child relationship before the injury or illness. Look at page 1428 of your textbook. This concludes part 1 of chapter 45.